time is on. Mr. Chairman. Mr. Chairman, time is on. Thank you.
Sorry, it's a technical issues and we are being acclimatizing this Zoom. So I'm again introducing that this is a good morning from Pakistan, and probably there are time zones, and I'm very excited and delighted that we are being connected from different continents. So it's a great opportunity of learning, and I thanks Professor Lin for taking this effort in arranging these whole cloud forum. So purpose of this cloud forum is the European Society of Cardiology in 2023 and TCT 2023 meetings. There are eye-catching clinical trials have shed brilliant light on our cardiovascular patient daily services for population. And the ILUMIEN, the OCTIVUS, and SWEDHEART, IFR and FFR registration established the importance of intracoronary lesion imaging, and this intracoronary lesion imaging has changed the whole game. So after imaging, you have a better idea for fixing the lesion and compare with the cabbage patients as well, versus lesion related to flow physiology in effective coronary revascularization and MACE reduction. The fire make clear no hesitancy attitude in complete coronary revascularization with acute STEMI and NSTEMI for elderly. The EVOLU low risk and partner 3 trials had demonstrated the long-term efficacy of TAVR or over SAVR for severe aortic stenosis with low surgical risk in elderly patients. On the other hand, ECLS-SHOCK depicts the dilemma of VA-ECMO support and emergency treatment of acute myocardial infarction with cardiogenic shock. And the BUDAPEST CRT Upgrade confirms the evidence regarding benefit of CRT-ICD upgrading in ischemic and non-ischemic HFrEF with depending RV pacing. So these are the lot of new things has been introduced in this year, and there are a lot of trials coming on. So basically, the purpose of these trials has to improve the patient's benefit. So today I'm going to introduce my co-chairman. He's Yoshiyasu Miyami. He's assistant professor, Department of Cardiovascular Medicine and Kitasato University Hospital, Sagamihara, Japan. So disclaimer of this cloud forum is the content on this webinar is copyright by APSC and should not be distributed without prior permission of APSC. The views and opinion expressed in this webinar are those of the faculty members and do not necessarily represent the APSC. And live streaming content of this webinar will be made available via Asian Pacific Society of Cardiology Cloud or APSC, Facebook, and YouTube. So let's start our program, and I'm going to introduce first speaker of this session. He is my co-chair, is Yoshiyasu Minami. He's again assistant professor, Department of Cardiovascular Medicine and Kitasato University Hospital, Sagamihara, Japan. He's going to speak on coronary revascularization strategies in the elderly with acute STEMI and non-STEMI, an implication from FIRE trial. So please.
Okay, thank you very much, Professor Chow. Okay, I will share the slide. Okay, so Professor Chow, can you see the slide, the title page? Okay, yes. Okay, thank you very much. So my topic is a FIRE trial, which was presented in the ESC meeting in this year. So this study had focused on the complete coronary, the revascularization in elderly patient, which was defined above 75 years old, concomitant with STEMI and non-STEMI. So this is my disclosure. Then before talking about the main context of the FIRE trial, I'd like to briefly mention regarding the background. So I mean, according to the increasing life expectancy in the world, particularly in these Asian countries, there, as you may know, the increased number of elderly patients with coronary artery disease, and that is kind of worldwide challenging healthcare issue. So these figures shows the percentage of patients with symptomatic coronary artery disease among elderly population, and left side is the data from Framingham Heart Study, and right side is data from cardiovascular health study. And as you can see, there are about 30% of general people may have the symptomatic coronary artery disease. And also, this survey has demonstrated the percentage of elderly people which may have the myocardial infarction shown on the right side. And in this data, the prevalence and the incidence of a myocardial infarction in general, the elderly population is about 10 to 20%. So we have, we have many elderly patients with coronary artery disease. And also, as you know, there are lots of specific characteristics in elderly patients with coronary artery disease. In particular, the large vessel coronary artery disease is a kind of headache. Because nobody knows what can be the optimal treatment for the multivessel disease in elderly patient. So regarding the multivessel disease among patients with ST elevation myocardial infarction, so as you know, the previous several clinical trials have demonstrated the clinical benefit of a complete revascularization than the culprit-only PCI strategy. Then these figures are from the study named complete study, which was presented the clinical benefit of complete revascularization than the culprit lesion only PCI. In addition to the complete trial, several other trials has also shown the clinical, the efficacy of the complete revascularization. So the current ESC guideline has strongly recommends the complete revascularization for the patient with STEMI and non-ST elevation ACS. Then in particular, for the patient with STEMI, the complete revascularization is recommended with class 1. And also, this complete revascularization should be performed either during the index procedure or within 45 days. For the patient with non-ST elevation ACS, complete revascularization is recommended with class 2A. So anyway, the complete revascularization is strongly recommended for the ACS patient. On the other hand, there are previous trials which has shown the clinical efficacy of complete revascularization. These study mainly included the patient with the age 60s. So, that's why, nobody knows, the clinical efficacy of complete revascularization can be applied for more elderly, more older the patient or not. So that's why, this 5-year trial was designed and conducted and presented in this ESC meeting, and also simultaneously published in New England Journal of Medicine in this year. So this 5-year trial was a randomized controlled trials, and this study included the patient with the age above 70 years old, and included both STEMI and non-STEMI with multi-vessel disease and successful treatment of culprit lesion. Then all about 1,400 patients were randomly assigned either culprit-only strategies or the complete revascularization strategy. The primary endpoint was the rate of patient-oriented composite endpoint, which includes all-cause death, myocardial infarction, stroke, and revascularization at 1 year. So this step shows the clinical characteristics in patient enrolled in this 5-year trial. And as you can see, the median age was about 80 years old, and most patients were hypertensive, and about 30% of the patient had diabetes, and about half of the patient had chronic kidney disease. Then about 35% of the patient were STEMI, and remaining 65% of the patient were non-ST elevation myocardial infarction. And about 30% of patients had the heart failure with a KIP class equal and more than 2. And mean left ventricular ejection fraction was 49%. And among patients allocated into the complete revascularization group, 232 patients underwent PCI for non-culprit vessel within the same index procedure for the culprit lesion. And 129 patients underwent PCI for non-culprit vessel several days after the index procedure. I mean, they were performed PCI staged fashion. And the location of non-culprit vessels were well balanced into the LAD 31%, circumflex 32%, and right coronary artery 33%. Then most non-culprit region, non-culprit vessel was physiologically assessed, and about half of the assessment was conducted by using the wire-based hyperemic index, and 35% of the region were assessed by the angio. Then finally, about 45% of non-culprit region was ischemic, and finally treated by the PCI. So these are the main results in this 5-year trial. So left side is a result of the primary outcomes, including the death, myocardial infarction, stroke, or coronary revascularization. And as you can see, their incidence of the primary, adverse event was significantly lower in patient with complete revascularization than the patient with culprit-only revascularization. And the hazard ratio was 0.73 and p-value was 0.01. And right side is a result of the key secondary outcomes. So this is a secondary outcome. So the p-value was not calculated, but hazard ratio is 0.64. And secondary endpoint was the cardiovascular death and myocardial infarction. So these are the so-called hard endpoint, and it looks, much better in the complete revascularization than the culprit-only revascularization. So this figure shows the sub-analysis according to the clinical characteristics of the patient for the primary outcome. And as you can see, irrespective of the age and the sex and the diabetes or not, and STEMI or not, the complete revascularization looks better than the culprit-only revascularization. And this table is also regarding the sub-analysis for the primary outcome, and they're irrespective of the LAD or not, or LV dysfunction or not, and the KILIP class or EGFR or not. The complete revascularization looks much better than the culprit-only revascularization. So this figure shows a result regarding the safety-related outcomes, which included the contrast-associated acute kidney injury and stroke or bleeding. Then, as you can see, the rate, the incidence was comparable between the groups. So the authors of these FIRE trials had concluded that in patients above 75 years old of age with MI and multi-vessel coronary disease, the physiology-guided complete revascularization was associated with a lower risk of composite of death, MI, stroke, or ischemic-driven revascularization than the patient with culprit-only revascularization. The authors also mentioned several limitations of the present study. And the first one is this study was open label design. So knowledge of the result of coronary angiography may have resulted in bias towards subsequent revascularization in the culprit-only groups. The second one is because complete revascularization was guided by physiological assessment. So the transferability of the result to angiography-guided complete revascularization is unknown. And the last one is whether the result may apply to management strategies or stent platforms that were different from the ones in this trial is unclear. So before finalizing my talk, I'd like to briefly mention regarding the multi-start AMI trial, which was almost simultaneously published in New England Journal of Medicine in this year. So this trial has tested the optimal timing of complete revascularization. I mean, they compared the immediate group, immediately, the complete revascularization within the index procedure versus the complete revascularization with the staged procedure. So this is the main result of, actually this was a non-inferiority study, but as you can see, the recurrent cardiovascular event, including the death, MI, stroke, unplanned revascularization, heart failure hospitalization, was significantly lower in the immediate group than the staged group, even if they are completely revascularized, but immediate group looks much better. So they concluded that among patients in hemodynamically stable condition with STEMI and multiplex coronary disease, immediate multiplex PCI was non-inferior to stage multiplex PCI with respect to the risk of the composite event at 1 year. And this was a non-inferiority study, but the event rate looks much better in the immediate group than the staged group. So in conclusion, from the result in the FIRE trials, physiology-guided complete revascularization strategy for elderly patients with STEMI or non-STEMI is an effective and safe strategy. So the message is that we don't need to hesitate to do the aggressive PCI strategy, even if the patient is the age is more than 75 years old. Then still, the several issues remains, including the timing of the revascularization and the angio-guided assessment is feasible or not. So thank you very much for your attention.
Thank you very much, Dr. Yasuyasu. I must say it was a great analysis of trials. And I have a few comments on this and your presentation, because this is a long-going topics we are listening from decades, that whether we have to fix culprit only or we will go for complete revascularization. One comment that is that benefit translated to younger population as well? Or any reason for selecting these patients more than 75 years? And in multi-star trial, what was the age of the patients in those? And besides this, I have one query that when we do early invasive like NSTEMI patients, sometimes it's very difficult to find out or label a culprit artery. Like any patient who's presented with NSTEMI with 3-vessel disease, then which is culprit? Sometimes it's very difficult. So is there any difficulty in randomization in FIRE trial?
Thank you very much. Yeah, actually, in particular in patient with the non-STEMI, it's quite tough to, decide, which portion was the culprit or not. So, to apply, this result for the daily clinical practice, we should be cautious, and we have to, carefully decide which region is a culprit or not. But, but for example, from the result of this study, if the patient is older age and non-STEMI and, the several title stenosis, and, it's sometimes, difficult to decide which one was the culprit or not. So in that case, if the hemodynamic condition is stable, then we can treat some of them or all, of them simultaneously, and that may be the better than the culprit only strategy. And also the multi-star AMI trial is not focused on the elderly population. So that, the study included all the age cohort. So we cannot directly apply that results to the elderly population.
Thank you very much. Any other comment?
Can I comment? Yes, Dr. Jawai, I would like to comment. Thank you, Dr. Minami. It was a great lecture regarding the latest publication. I would like to comment regarding the physiology study that is done in the FIRE trial. It is, if we see at the full text of this publication, the physiology study is wire-based like FFR or IFR, and they also use angio-based physiology study like the QFR. Can you elaborate more of this kind of physiology study, because there are multiple physiology study that is done for this population. And the second thing is the definition of immediate versus stage PCI for multifacetal STEMI. Sometimes it is not very easy to do all the PCI, all the stenting during the midnight hour in the STEMI patient. So, and there are also a definition of immediate, although it is an index procedure, meaning that the patient, when the patient came at the first time, or the patient before discharge. Before discharge, meaning it's probably a few days after the STEMI. And stage PCI, of course, there are multiple definitions also. If it is based on complete trial, it is up to 45 days. Probably you can elaborate more by the definition of immediate, because sometimes it is not easy, especially when the lesion is CTO, calcified, left main of non-culprit. It is not very easy to do during the midnight hour. Thank you.
Yeah, thank you very much. Yeah, I agree with the comment regarding the physiological assessment, and also regarding the difficulty and the complete revascularization in the mid-time. So yeah, I think that, you know, in such case, you know, we can, you know, stop the procedure for the culprit only in the midnight, and, you know, several days after we can, you know, retry the revascularization for other breakthroughs. So anyway, I think, you know, the both trials has suggested that the revascularization should be performed in the early stage, not too late. Thank you very much.
That's a great comment by Amir Aziz, and it's a great thing to point out, because there are still things are vague, and we know, we have learned from years of practice that things are changing, and this is a good thing. We are looking for at least elderly patients have documented benefit in this strategy. Probably that benefits are translated to younger population. So thank you very much, Yashasu. Moving to next talk, Dr. Duyun Kang has joined probably, and he was busy in cath lab prayer, but he has joined. So Dr. Duyun Kang from Korea is our next speaker. He is Assistant Professor of Interventional Cardiology at Asan Medical Center, University of Alasan College of Medicine, Seoul, South Korea. And Dr. Kang is going to talk on optical coherence tomography, or IVUS ultrasound on angiography guided intervention in high risk coronary lesion, implication of ILUMIEN and OCTIVUS trial. So over to you.
Thank you for your kind introduction, Mr. Chairman. And I am Dr. Duyun Kang from Asan Medical Center, and because I am the first author of the OCTIVUS trial that was presented and published in circulation in the ESC hotline. So I will briefly summarize the ILUMIEN 4 and OCTIVUS and other OCT guided or IVUS guided PCI result in high-risk patients. I do not have any relevant financial relationship to disclose. Intracoronary imaging guided PCI for complex coronary artery lesions showed superior clinical outcomes compared to angiography guided PCI. IVUS XPL from Korea with the long lesions showed a 52% risk reduction of the MACE at 1 year after long lesion PCI. Ultimate trial for all-comer PCI from China also showed about 50% target vessel failure reduction at 1 year compared to angiography guided PCI. Also, I've seen improved clinical outcome in CTO PCI in CTO IVUS RCT. It also decreased the cardiac death MI or TVR more than 50%, about 70% reduced with IVUS guidance. And also, IVUS use was associated with a better 10-year outcomes after left main PCI that I published with the main compare registry. More recently, another trial from Korea, Renovate Complex PCI RCT, that was published in the New England Journal of Medicine with the bifurcation CTO left main long region, multivessel ISR calcification, that showed decreased target vessel failure, about 40% risk reduction at 3 years. So now we know that intravascular imaging use in complex lesions decrease cardiac event. Then how about the OCT and IVUS, other devices? Because major trials was done in intravascular ultrasound with a more long history, OCT, the data is weaker than IVUS. Current US guideline recommends 2A for the IVUS for complex PCI and OCT as a reasonable alternative as a 2A recommendation. European guideline also recommends IVUS or OCT to optimize stent as a 2A recommendation. And to add the evidence of the OCT-guided PCI benefit, the ILUMIEN 4 study was done. This is the full name of the ILUMIEN study, ILUMIEN 4 Optimal PCI, that was published in New England Journal of Medicine by Dr. Jihad Ali. This is the presentation slide that Dr. Ali used in the ESC Hotline conference. In ILUMIEN 3, OCT guidance improved procedural success with the angiographic guidance, with a great stent expansion, and reduced major malposition and major dissection. However, the number was very small, just 150 patients. So they evaluated a large number of the patients in high-risk PCI to confirm the benefit of the OCT guided PCI compared to angiographic guidance PCI. They randomized the patient one by one, and OCT guided PCI was done, and angiographic guided PCI was done. Importantly, the post-PCI OCT was done and blinded in angiographic guidance in both groups. So primary imaging endpoint was acute minimal stent area, and primary clinical endpoint was target vessel failure at 2 years. And this is the definition of the high risk, the diabetes, and non-STEMI, and STEMI more than 24 hours, long or multiple lesions, 28 millimeter, ISR, severe calcification, CTO, and bifurcation with the 2 stents. And the point was a post-PCI minimal stent area with a superiority hypothesis, and target vessel failure during 2 years with a superiority of the hypothesis. They are 2 powered endpoints. And 2,487 patients were randomized one by one, and then about 95% of the patients completed 2-year clinical follow-up. And the mean age was 65, and 77% of the male patient, and about 19% of the smoker, and 40% of diabetes mellitus. Acute coronary syndrome was about 60%. And the DM patient was 40, and long or multiple lesions about 67, and non-STEMI 24%. But I can say that the anatomically complex lesion patients were not so many enrolled. You can see that angiographic severe calcification patient only 11, ISR 10, CTO 7, STEMI 5, and bifurcation only 3%. So major patient was enrolled by the criteria of the diabetes mellitus, and long lesion more than 28 millimeter stent. And in angiographic evaluation, major vessel was LAD, and the severe calcification was in angio was the 32%, and diameter stenosis about 70%, and lesion length was 30 millimeter in angio. And about 1.7 stent was implanted with a 42 millimeter in the average, you can see that the stent length is longer in OCT guided group, and stent diameter is larger in OCT guided group, with the more post-dilation balloon, with a bigger maximal device size and higher inflation pressure. This is the primary imaging endpoint with the final post-PCI minimal stent area measured by OCT, larger, about 0.36 square millimeter in OCT guided group. Stent expansion was better in OCT guided group, and post-procedural major dissection was less frequent in OCT guided group. Also, malopposition was less frequent in OCT guided group. The angiographic complications like dissections, low flow, thrombus, or perforation, distal embolization was less frequent in OCT guided group. However, target vessel failure at 2 years was not different between groups. Red line is angiographic guided PCI. Yellow line is OCT guided PCI. 8.2 versus 7.4% with a hazard rate of 0.90. That showed no superiority was shown. Cardiac death, no significant difference. Target vessel MI, no significant difference. A little bit smaller, a little bit lower in OCT guided, but no difference. Ischemia-driven TVR, no difference. Stent thrombosis was significantly lower, 0.5 versus 1.4%, and lower in OCT guided group. This is the detailed list of the clinical outcome that showed no significant difference between groups. The others explained that there was some impact of the COVID. Pre-COVID era, there was some favorable event in the OCT guided group, but after COVID, there was no difference, and they explained that many patients did not undergo target vessel revascularization. So the others concluded that OCT guidance resulted in larger MSA with a better span expansion and fewer major dissection or malopposition with a better angiographic complications. However, the 2-year rate of the target vessel failure was not different. However, just stent thrombosis was reduced. And there was some trend with the fewer cardiac death and MI, but not significant. And rates of the TVR were lower than expected. Also, there was some impact of the COVID. But I think that would it be real COVID impact? I think that it would be a learning impact. Before COVID, that means that the early period of the patient, there was some learning period because they used post-PCI OCT also in angiographic guided group. That means operators, yes, they were blinded, but I think that though if there was some very big problem or something like that, the operator would give feedback with the OCT, a final OCT, and then maybe the clinical outcome and the stent strategy with the angiographic guided PCI also improved with the OCT feedback. That's my personal opinion. That's why the early period and late period showed different clinical trend. At the same session in ESC, also October trial with the Europe that was presented and published in NEJM. They enrolled 1,200 patients with a complex bifurcation lesion, and angio versus OCT guided PCI was done. OCT guided PCI showed better superior MACE at 2 years than angio guided group with a hazard ratio 0.70. And there was the trend of the less cardiac death, target vessel MI, and ischemia-driven TLR. So there was some conflicting result in ILUMIEN 4 there was no difference. And October, OCT was better. And also, as I said, in ILUMIEN 4 trial, the less complex patient with just diabetes mellitus were enrolled, and that would be the lower complexity would be another cause of the no benefit in OCT-guided PCI. There is another trial that's ongoing, comparing OCT versus angio-guided PCI in 1,600 by one randomization in Korea. They included AMI, CTO, long lesion, calcified lesion, the lesion-based complex lesion, and did not include only diabetic patient. And primary endpoint is MACE at 1 year, and maybe the result will be presented next year ACC. And with the OCCUPY result, we will have the more stronger evidence whether OCT is helpful or not. And however, I will present the next trial, our trial OCTIVUS trial. OCT and IVUS have shown comparable clinical outcomes in guiding PCI in previous trials. ILUMIEN 3 optimized PCI trial with 150 patients in each group showed non-inferior final post-PCI minimal stent area by OCT compared to IVUS. An opinion trial from Japan that randomized 800 patients and underwent 8 months follow-up angio and 12 months clinical follow-up also showed non-inferiority of the OCT compared to IVUS-guided PCI. And another MYSTIC 1 relatively small sized trial also showed the in-segment minimal lumen area that was not non-inferior in OCT-guided PCI. However, there are some limitations of prior 3 RCTs with a relatively small number of the patients to underpower for clinical outcomes, and complex lesions were excluded like left main, triple cell disease, ostial lesion, CTO, ISR, and follow-up angiography was performed. So we designed and published the OCTIVUS trial result. There was the prospective multicenter randomized open-label trial that enrolled all patients by OCT versus IVUS-guided PCI, and the 1-year target vessel failure was shown non-inferiority of the OCT-guided PCI, and presented in Handline in ESC and published simultaneously in Circulation. And I did some more sub-study with the complex PCI patient, and the result was the presented in TCT in the clinical the hot topic in clinical research, and published in JACC. This is the key subgroup analysis of the OCTIVUS trial with the only complex coronary artery lesion from OCTIVUS trial. I included unprotected left main, bifurcation, ostial lesion, CTO, severely calcified lesion, ISR, and long lesion with a 38 mm or more, and multivessel PCI. An imaging-guided PCI was performed using standard technique following EA PCI expert consensus, and all results were measured by the independent imaging core lab. Study outcome was target vessel failure, composite of cardiac death, target vessel MI, or ischemia-driven TVR. And the main analysis was performed in the age-treated population because it's the post-hoc analysis of the main trial. And also the outcomes were compared with the use of the propensity score adjustment, IPTW, and overall propensity score weighting. Among 2,008 patients in main OCTIVUS trial, 1,475 underwent complex PCI, and 719 and 756 patients underwent OCT versus IVUS-guided PCI, and over 99% patients completed over 12 months follow-up. The mean age was 65, and female sex was 21%, and diabetic patients 36%. And previous PCI history was more common in OCT-guided PCI. And left main was about 70%, any bifurcation more than 70%, OCTL lesion 13%, and CTO 7%, ISR 11%, severe calcified lesion 10%, a long lesion 55% with a mean syntax score 18. And the total number of the lesion and total number of the stent per patient was 1.8. I think that is a bigger number than the ILUMIEN 4 trial, and total stent length 56 millimeter longer than ILUMIEN 4 trial. And the total amount of the contrast media used was larger in OCT-guided PCI, but the procedure time was shorter in OCT-guided group. Procedural success in angiography was similar between group. However, imaging-based success rate was lower in OCT-guided PCI group. Procedural complications was higher in IVUS-guided PCI. And QCA result, no definite difference between group, except for a little bit the higher diameter stenosis, just 1% in IVUS-guided PCI group. And in core analysis of the imaging, OCT IVUS themselves, minimal stent area is smaller in OCT-guided group because the inherent the measurement, the character that OCT shows smaller lumen area than IVUS measured lumen area. And optimal stent expansion was lower, and the plaque burden at the stent landing zone was the bigger in OCT-guided group. So all stent optimization criteria met, rate was lower in OCT-guided PCI group. However, the primary outcome of target vessel failure at 2-year median and maximum 4.8 year was not different between groups with a hazard ratio 0.87, and the secondary endpoint was not different between groups. However, the target vessel MI was lower in OCT-guided PCI, including peri-procedural and spontaneous MI, with a lower trend in OCT-guided group. Also, the sensitivity analysis with the IPTW or overall PS weighting adjusted population showed the same trend with the same trend of the lower target vessel MI in the OCT-guided PCI. The subgroup analysis by anatomical factors also showed no difference between groups. However, in ISR lesion, OCT showed a benefit compared to IVUS. So the OCTIVUS trial has some limitations because the number of the primary outcome was small, lower than expected, so there is some statistical underpower. And it was not possible to mask the imaging modalities, so there can be some bias. And then also there can be some discrepancy of the on-site determined and core measured imaging interpretation. And the generalizability of the finding may be potentially limited because this study was done in Korea that is very high rate of the imaging use. And we did not perform the cost effectiveness analysis of the two imaging modality. So this overall analysis of the OCTIVUS trial with a complex lesion, OCT and IVUS guided PCI showed similar target vessel failure. Target vessel MI or procedural complications was lower in OCT guided group, and the ISR lesion OCT showed better clinical performance. So we concluded that the two devices are similar in guiding the complex coronary lesions. And this is the slide from the David Capodanno presented in the same session that showed the network meta-analysis between the OCT, IVUS, and angio. They showed any imaging device versus angio showed clinical benefit. IVUS showed the clinical clear benefit compared to angio, and OCT in direct comparison, it was not significant because of the ILUMIEN 4 trial, but in direct and network analysis shows the benefit to angio-guided PCI. OCT versus IVUS, not including the OCTIVUS trial, that showed no significant difference between two imaging devices. And OCT still does not have clear benefit in the secondary endpoints, so need more data. So this is summary. Current US guideline recommends the IVUS in the complex lesion setting and OCT as the alternative. I hope that the guideline recommendation of 2A for IVUS would be elevated in the future, but OCT would need some more strong data. So intracoronary imaging guidance showed consistent benefit. ILUMIEN 4 2-year rates of the target vessel failure was not different. October showed benefit in OCT guided PCI, and OCTIVUS subgroup analysis that the similar OCT and IVUS guided PCI outcome. So IVUS guidance has strong evidence, and evidence for OCT is accumulating, but it remains less persuasive and needs stronger evidence. IVUS and OCT should be seen as complementary rather than mutually exclusive technique, and we have remaining questions that who would be the optimal candidate for OCT or IVUS. Thank you for your attention.
Thank you, Dr. Kang. It's an excellent overview of imaging, and we know from the history that imaging is evolving from year and year, and hopefully the benefits definitely are obvious once imaging is introduced in coronary intervention. But from the part where I am working, I feel bit confident at this time that because of cost, we have a lot of restriction using this imaging technique, but still coronary angiography guided angioplasty has a role, but definitely in future the things are being changed and imaging will come more and more in this coronary intervention. So thank you again. Any comment from our colleagues, our panelists, or our speakers?
Can I have the one question? For,
yes, please.
Dr. Kang, thank you very much for your wonderful lecture. Because my major is OCT, so I'm very happy to have an opportunity to directly discuss this topic with you. Then in the OCTIVUS trial, you have shown that the comparable incidence of contrast-induced nephropathy in OCT group and IVUS group. But I remember you excluded the patient with chronic kidney disease, right?
Yes, we excluded the patient with GFR less than 30.
Okay, less than 30. Oh, I see. So do you think, is it still better to use the IVUS for the patient with chronic kidney disease? Or could you please give some comment regarding that point?
Yeah, actually, as I said, we excluded the very severe CKD with a GFR less than 30 and without dialysis. So I don't know about the very severe CKD. However, the patient with the GFR 30 to 60, the mild CKD patient were treated very well with OCT because we now have many techniques that reduce the contrast agent during the OCT evaluation. And also we have some other alternative devices in the like Dextran or like something like that. So I think that the OCT guidance is also it can be done also in the mild CKD patient. Our data says that with some caution, because we need to we should try to reduce the contrast agent, and the data shows that it is okay. Still, for my personal bias, I prefer IVUS for some CKD patient. However, the data shows that the safety of the OCT even in mild CKD patient.
Oh, thank you very much. Yeah, we don't need to worry so much about the.
Yes, that's right. We did not need to worry so much.
Thank you very much.
Thank you very much, Dr. Kang. It's time to move to another speaker.
Thank you.
Now we have third talk will be delivered by Dr. Amir Aziz Al-Kathari from Indonesia. He's interventional cardiologist, National Cardiovascular Center, Harapan Kita Hospital, teaching staff, Department of Cardiology, Faculty of Medicine, University of Indonesia, Jakarta, Indonesia. And Dr. Aziz is going to talk on clinical outcome and MACE comparison between intravenous wave free ratio, that's IFR, and FFR guided coronary revascularization. It's an insight from SWEDHEART SWEDHEART Association. So please, Dr. Amir Aziz.
Well, thank you very much, Mr. Chairman. So I think thank you for the invitation. Today I would like to discuss with you regarding the latest publication as well as the latest presentation from ESC 2023 as well as TCT 2023 regarding this issue, clinical outcome and MACE comparison between IFR versus FFR guided coronary revascularization insight from the SWEDHEART registry. So I don't have any conflict of interest for this presentation. So we understand that we know that there is some limitation of coronary angiography. I think Dr. Kang just now elaborate regarding the role of intravascular imaging. But today I would like to discuss regarding the physiology study because of some limitation of coronary angiography PCI. So from the latest publication, we understand that in the cath lab, we have so many tools to measure the physiology study. The first, of course, publication is from the FFR, which is using a hyperemic agent such as adenosine. But since there is some limitation of this hyperemic agent, whether it is the cost or it is the procedure time, as well as the availability on, of course, the cost in some countries is not that cheap. There is some non-hyperemic index that is also developed, such as the IFR, RFR, and others. And if we see that this non-hyperemic is just using the wire pressure ratio, so it's not using hyperemic agent because it measures during the wave-free period, which is in the diastolic period. And also, there is also some improvement in angiography-derived FFR. From just the angio, we can measure the physiology study using the theory of computational fluid dynamics, such as the QFR, FFR angio, and VFFR. Of course, from this, QFR have more data compared with the other index. And also, we understand that the latest guideline from 2017 of ESC and also ACC/AHA 2021, which is published 2022 in circulation, also mentioning about the role of FFR or non-hyperemic pressure ratio, which have more data, like IFR, for particular, have a recommendation of 1A. And also, there is some observational study on registry studies, such as the SCAR registry data, also showing that the benefit of mortality and also reduced restenosis and stent thrombosis if you use physiology-guided PCI compare with angio-guided PCI. So I think regarding the cutoff of FFR, we understand that 0.8. Previously, I think from Dr. Pills, the cutoff is 0.75, but it is from the latest guideline, I think the recommendation is 0.8. And IFR also other non-hyperemic pressure ratio using the cutoff of 0.89. And we also understand that the IFR technology comes from because of there is some wave-free period in diastolic period that does not need any hyperemic agent. And also there is some confirmation from a few studies showing IFR validation that demonstrate 85 degrees agreement with fractional flow reserve or FFR. And this is, I think, one of the famous publication of IFR SWEDHEART and defined flare, which is published in the same year, not only the same year, but the same publication of New England Journal of Medicine 2017, showing that the IFR was non-inferior compared with to FFR at 1 year study. And also, there is some publication last year confirming the 5-year outcomes of IFR versus FFR, showing that no difference in MACE, death, MI, and unplanned revascularization at 5 years. So please remember, this is the IFR SWEDHEART study, but there is some difference in the 5-year outcome when it comes to defined flare, which is delivered by Professor Escanet during EuroPCR a few months ago, showing it tends to have more MACE in the IFR group. So if we elaborate more, the MACE is actually the same after 5 years, but there is some mortality issue that is increased in the IFR arm. But what is very interesting that the mortality increasing in the MACE treated patient. So it is in the patient that is treated with PCI, not the one that is not treated. So this is if you see the European Heart Journal publication and also the editorial, they raise this issue. This result is a play of chance, or is it in fact a true effect? So even the author, Dr. Mirfat from Saudi Arabia, in the editorial of European Heart Journal, is asking, is it time to revisit the current guidelines? So, the author of this SWEDHEART, IFR SWEDHEART, tried to elaborate more during the TCT presentation. They try to dig deeper in the SWEDHEART National Registry analysis that comprised 42,887 patients. And also, what is very amazing is they can track 100% of all patients of this follow-up study. They try to see how is actually the follow-up result outcome comparing FFR and IFR in this registry. But if we can see that it is not really comparable, because the IFR is more often utilized in women, diabetic, MI, stroke, and COPD. Of course, this is a registry, not the RCT. Sometimes there is some not really comparable baseline characteristic. And also, we can see that this the treated IFR group tends to be older, more often women, diabetic, hypertension, and stroke. And if we see from this analysis of 42,000 registry patients, showing that in the 5-year MACE, it seems that it really do not have any differences between the IFR and FFR. And also try to see the other outcome like all-cause death, myocardial infarction, and unplanned revascularization in 5 years is also the same between the two groups. They try to see whether there is some difference between the deferred patient and the treated patient, and the result is also the same. No interaction between the treatment decision and the outcome. And also the myocardial infarction between the deferred patient and also the treated patient is also the same. And also for the outcome of unplanned revascularization. If we, and also there is some group analysis of 5-year MACE. If you can see whether they compare within between the old patients or smoker patient or diabetic patient, or is no difference in MACE between the IFR and FFR in any the subgroups. So I think it is very interesting because it's still until now it is conflicting data, although it is already guideline of and recommendation of 1A. And the summary of Professor Gothenberg in the last TCT last month presentation is in National Registry analysis of 42,800 investigated IFR and FFR with follow-up of 5 years. They have they concluded there is similar outcome between IFR and FFR, although MACE, all-cause death, myocardial infarction, and unplanned revascularization. And the second summary from this SWEDHEART registry is the observed difference in mortality between IFR and FFR among treated patients in defined flare could not be verified in this large nationwide real-world all-comers registry. Just to give a flavor of this topic, I would like to share just a case, two cases regarding the use of IFR. This is a 64-year-old male with a stable angina with hypertension, smoke, and dyslipidemia as a risk factor. And we can appreciate there is some disease in the proximal LAD, although it is not really a tight lesion, but there is tight lesion in the left circumflex, in the proximal part. And in the right coronary system, we can appreciate there is some disease just before the bifurcation. You can see it depends, although you may say it is a 50% or 60% or even 80%. So how would you treat this lesion? So if you do from the angio, you probably will just do everything, probably PCI RCA or LAD, which is probably not because it's not really a tight lesion, but CERC probably, or just leave it, or physiology assessment. So we go further with try to do the physiology assessment with using the non-hyperemic index such as IFR, showing that the IFR is positive in the CERC, although it doesn't seem to be very big vessels, and the IFR of LAD is non-significant. And the interesting one is the IFR result of RCA, which we think is 70% or even 80% is normal. So this we try to use a IFR with co-registration to do some kind of virtual stenting by the software, showing that if we stent with like 28 mm of proximal of the CERC, we can get 1.0 IFR after the PCI. So of this patient, because it is quite focal and also quite long there. So we use a 2.0 as a lesion preparation and stent with the drug-eluting stent 2.75. We go further than it is said, 28, we go 33 because we want to cover all the lesion, and then a post-dilate with a 3.0, 15, and these are the result of the CERC, which is actually it's not really small vessels. So after the PCI, as the virtual stenting mentioned, that it is actually the result is 1.0, exactly like the software told us before. So this is the second case. It's probably have something to do with Dr. Minami lecture also. 70 years old, acute anterior STEMI with hypertension and diabetic as a risk factor, F 40%. And this is the ECG, definitely this is a STEMI, anterior STEMI. And this is a primary PCI at the 3 a.m. in the morning. So we can appreciate that the CERC is diseased, the distal RCA is diseased, and also the total occlusion of the proximal to mid LAD with some disease also in the proximal part. So you can see that after we did POBA of LAD using a 2.5, 20 mm, you can appreciate there is some teeny tree flow up to the distal part of the LAD. Of course, there is something, there is disease there. And also at that time, we decided to do a heart team discussion because this is a triple vessel disease, whether we want to stent all the way or we just send the patient to the surgery. There is some debatable RCA lesion significance. It is probably quite dominant angiographically, but short and distal and small caliber of the CERC. Our surgeon does not really want, is quite reluctant. He's quite reluctant to do the graft for this CERC. So we decided to do IFR and IFS guided PCI. So there is some issue also using the FFR on IFR study in the acute settings. So this is a publication from the JACC confirming there is some difference between if you use IFR or FFR during acute setting or subacute or even the stable setting, but I think the result is not that significant. So based on this paper, I think we can use in the subacute setting or just a few days after the STEMI. So for starting for IFR, the RCA, day 3, before the discharge, so what the lesion that we thought it is quite significant is actually the IFR result is 0.97. So we try to see further with the intravascular ultrasound, but it seems that the IFOS result, the MLA, minimal lumen area, is not that small. You can appreciate that the lower is 6.3 mm. At the lesion that we thought it is quite significant. And so we left the RCA, we didn't do anything. The CERT is we just a POBA because it is small vessel. And the IFR of LAD, we check again a 0.72 after 3 days of POBA. And stent length estimation as well as the co-registration using IFR. And this is the co-registration. So we based on this, we pre-dilate the lesion, stent with the 2 drug-eluting stent 3O and 4O, and do post-dilatation. And these are the results, as well as the IFR measurement after we did 2 stents of the LAD. So this is the result of post-PCI IVUS, showing it's quite well opposed. With stent area is, I think is more than 10 or more than 15 at the proximal part of the LAD. It's quite big. With aneurysmatic area, of course. And this also the post-PCI after we did NC of 4.5 at the proximal AD. Of course, if we don't use the intravascular imaging, I myself is quite afraid using 4.5 in the proximal LAD. Probably we do it for the left main, but not from LAD. But since we have correct data from the intravascular imaging, so we did 4.5 NC balloon. So with that, I think thank you very much for your attention.
Thank you, Dr. Amer Aziz, giving the whole spectrum of this physiology of vessel. And we know from the landmark trial FEM that in the coronary physiology has the pivotal role in treating the vessels, but it's the excellent cases you have shown. And we know that coronary physiology is very useful in determining, because putting a stent everywhere doesn't solve the problem. So, but from your data, it's clear that still IFR and FFR has equal efficacy and potency in deciding which vessel is to be stented. So if we are, I think we are on right time. So after completion my task, I will request my co-chair Yeshua Subinami to take over from here and introduce next speaker of the session. Thank you.
Okay, thank you very much, Professor Chow. And I will be chair the last 3 sessions. So I'd like to introduce the first of the last 3 speakers. Then first will be the Dr. Liu from Taiwan, and he's a visiting staff section of cardiology, cardiovascular center, direct animal center for Eastern Memorial Hospital in New Taipei City, Taiwan. And the topic of his talk is a dilemma of extra cochlear rise support in interventional management of acute myocardial infarction complicated with cardiogenic shock interpretation of ECLS-SHOCK trial. So are you ready to present? Okay, please go ahead.
Thank you very much, Chairman. And the background, about 10% of the patient with AMI complicated by cardiogenic shock. And the overall mortality is about 40 to 80% within 30 days, despite revascularization and also the mechanical circulatory support. And in the patient with cardiogenic shock, mechanical circulatory support may improve both systemic and myocardial perfusion and reduce ventricular workload, and also may provide peri-procedural support for PCI. And based on the current guideline and clinical practice,
excuse me, Dr. Chai, is your PowerPoint display right now? We are in the first slides.
First slide?
Yeah, sorry. Do you need to show the?
Let me.
Yeah, please show the first.
Yes, I.
Try again. Thank you.
Yes. Okay, can you see this?
Now, can you make a full screen? Okay.
Okay.
Thank you.
Thank you. And based on the current guideline and the clinical practice, ECLS is increasing using in the treatment of infarct-related cardiogenic shock. However, there is lack of evidence regarding its effect on mortality. Based on previous randomized clinical trial from the shock study and triumph study, APP shock 2 study, and the couplet shock study, you can see that even the definition of the cardiogenic shock is a little different, but we can see that the mortality rate is about 40 to 50%, despite the IBP mechanical support and other medication. And the slide is for introduction of the current available temporary circulatory support. We can see for the RV support, there is Impella RP, Temden Heart RAPA, and also VA-ECMO. The VA-ECMO can offer the support for the RV and LV support. And VA-ECMO can support the cardiac flow for about up to 7 liters per minute. And IPP, and there is also Impella, offered about 2.5 to 5 liters per minute, and Temden Heart and IFAC 12. And we can see that the VA-ECMO offer no LV unloading. However, the IBP, Impella, Temden Heart, and IFAC 12 offer the extra LV unloading. And based on the current guideline, in patients with acute coronary syndrome with cardiogenic shock, short-term mechanical circulatory support may be considered. And the routine use IAPP in cardiogenic shock is not suggested based on the IAPP shock 2 trial. And for the slide, we can see based on the clinical practice and the current guideline, there is the use of the VA-ECMO is increasing over time. And the process of the ECLS-SHOCK study is that early routine ECLS treatment as compared with usual medication therapy alone will result in improved survival in patients with AMI complicated by cardiogenic shock, for whom early revascularization was planned. And this is a prime endpoint of the ECLS-SHOCK study, the 30-day all-cause mortality. And this is the second endpoint. And the sample size is based on the estimated event rate of the 49% mortality in the control group and 35% in ECLS trials, and use the two-sided chi-square test with a power 80%. And the inclusion criteria of the study is the cardiogenic shock complicating AMI plus current revascularization or systolic blood pressure less than 90% for more than 30 minutes, or catecholamine used to maintain systolic blood pressure over 90% mercury, millimeter mercury, and also the signs of impaired organ perfusion like altered mental status, cold clumping skin and extremity, oliguria, and also arterial lactate more than 3 mm. And the main inclusion criteria is the resuscitation more than 48 minutes and mechanical cause of cardiogenic shock, onset of the shock more than 12 hours, and other severe PAD. This is the flow chart and the involve many the medical center in Germany and Slovenia. Initially, it's the randomized 2,020 patients, with one versus 1 ratio. And this is a baseline characteristics. The median age is about 62 years old. And we can say that the median of EF around 30%, and the lactate is around 68. And we can see that the scale shock preservation range from C to E. About 50% of the patient is in the C class. This is the SCAI status of a cardiogenic shock. You can see the class G is the clinical evidence of hypotension and hypoperfusion, and the class D is the clinical evidence of shock, and the E is the refractory shock. And about 95% of the ECLS group receive PCI, and about 91% of the group receive the ECLS therapy. And we can see that there is also the active LV. The active LV unloading in ECLS group is only 5.8, but we can see that in the control group there is additional active LV unloading in 6 out of 19 patients, and also there is about 5% of the control group received the mechanical security support. And also there are 26 patients in the control group received the ECLS therapy. And for the primary endpoint, the 30-day mortality, we can see that there's no difference in the ECLS group and control group. The mortality rate is about 49% in the ECLS group and 49% in the control group. And for the key secondary endpoint, we can see there's no difference in the arterial lactate range from within 2 days after the ECLS. And there is no difference in the renal function and the SAPS-2 score, the active physiology score. And for the safety issue, we can see that there is much more moderate or severe bleeding in the ECLS group, about 23%, and it's only 9.6% moderate and or severe bleeding in the control group. And also the peripheral ischemic vascular compression requiring surgical or interventional therapy, the ECLS group is much higher than the control group. And for the subgroup analysis, we can see there's no difference in the sex, age, diabetes, type of infection, STEMI type, or arterial uptake, or CPR. The patient with CPR is about 48% in each group. However, there is no shock severity stage in the subgroup analysis. And how about other randomized clinical trials? The first randomized clinical trials is the ECLS-SHOCK one-stop trial, also conducted in Germany. And there is a very small number of the patients. The number is 21% in the mechanical security support and also in the control group. The primary endpoint is LV ejection fraction. There's no difference. And the survival probability, the 30-day mortality is also similar. And another randomized control study is the ECMO CS trial conducted in Prague. And the aim is to compare immediate implantation of VA-ECMO versus initial conservative therapy. And the conservative therapy allows the downstream use of VA-ECMO in patients with rapidly deteriorating severe cardiogenic shock in AMI patients. And we can see that the primary endpoint, the composite of death, resuscitated circulatory arrest, and implantation of other mechanical support at 30 days. There's no difference in the composite endpoint. And for the all-cause mortality, we can see that in the ECMO group is 50% and conservative group is 47.5%. There's also no difference in the all-cause mortality, but there's a little trend for the more mortality in the ECMO group. And there's another renal trial is the EVOLU trial. The purpose of the trial is to determine if early use of VA-ECMO will improve outcomes in patients with persistent cardiogenic shock following PCI. And the study stopped earlier because of the COVID-19 and poor enrollment of the patient. We can see also there is a trend favor the ECMO use, but the number is limited. So there's a meta-analysis just published in Lancet. For the clinical trials mentioned above, the 4 clinical trial, and they use finally they enroll the 4 randomized clinical trial just mentioned before. And from here we can see this is the meta-analysis. We can see the ECMO, the ECLS-SHOCK 1, ECMO, the ECLS-SHOCK 1, EVOLU and ECLS-SHOCK study. The trend is favor VA-ECMO. However, the ECMO HCS is favor the conventional therapy. And in the all-cause mortality based on the intention to treat, there's no difference. And for the IPT meta-analysis, there's no difference in the subgroup analysis based on the age, gender, lactate level, cardiac arrest, the MI type, or the TIMI flow. And the summary of the ECLS-SHOCK study and the meta-analysis is that in patients with AMI and cardiogenic shock, ECLS versus control the ECLS doesn't reduce the all-cause mortality. And also the lack of mortality benefit is supported by the meta-analysis trial. And the lack of mortality benefit is further supported by the fact that there is no difference in the secondary endpoint like lactate, renal function, and SAVR score. And ECLS, however, ECLS is associated with high rate of moderate or severe bleeding and peripheral ischemic complication requiring intervention. And the finding changed the current guideline and clinical practice, increasing the rate of mechanical support in cardiogenic shock. However, there are some questions regarding these clinical trials. The first one is for the ECLS-SHOCK study, we can see there's escalation to IBP or percutaneous vascular device in 28 patients in the control group. And also there is 26 patients close to ECLS. This is a treatment. We can see in the control group there's 46 and 26 and received the ECMO, and also 28 patients received the other mechanical support, meaning the impeller. And also for the unloading during ECLS therapy, there's 11 out of 191 patients, about 5.8% receiving the active unloading, and there is also active unloading in the control group. And the second question is the ECMO doesn't unload LV and might increase afterload. As in the previous study, we can see the peripheral ECLS insertion is associated with increased LV afterload owing to retrograde aortic flow. And in animal study and in some observation study, LV unloading might reduce wedge pressure, improve pulmonary edema, LA pressure, decrease LV distension, improve ECMO output, and improve LV injection fraction, and improve ventricular arrhythmia reflected to medication. And also, however, the unloading rate of the ECLS the group is only 5.8%, is low. And further randomized trials are needed to escalate whether unloading affect outcome in ECLS treatment. And we can see that for the current mechanical circulatory support, the VA-ECMO offer no benefit of LV unloading, and other like impaired antenna heart and IPV offer the active LV unloading. And so in the some of the patients will use the DAFA ECMO for the after the atrial septostomy and put the feed drain into the LA, especially in the LSPV. And what's the benefits of active LV unloading? At present, there is no randomized trial, but based on the study just published in the JACC heart failure, they collect data from the 4,021 patients with cardiogenic shock, and then the 18 tertiary hospital, and the patient with device implantation is early VAS delay that defined by implantation before 2 hours after VA ECMO. We can see in the outcome, we can see there's benefit in the 30-day mortality, and also favor the stroke in the active LV unloading. And in the extreme, we can see there is the clinical benefit in the early active LV unloading after VA ECMO insertion. And LV unloading until 2 hours after VA ECMO offers the 36% lower relative risk of 30-day mortality, and there is no increased likelihood of complication. And we can see there is a gradual increasing mortality risk with every hour delay of the active unloading. So the ECLS ECLS-SHOCK used for patients with MI and cardiogenic shock doesn't improve 30-day mortality versus control group. However, we can see in the ECLS-SHOCK study, there's about one-fourth of the patient in the control group receive mechanical circulatory support. And also, we can understand that the MI with cardiogenic shock is not mean ECMO only, because the ECMO, we could consider the phenotype of cardiogenic shock. For example, the RV or LV failure, and also the brain, and also the damage of the LV dilatation in the ECMO use. So will the patient need LV unloading? So this is the take-home message. In patient with AMI and cardiogenic shock, brain revascularization, ECLS versus control doesn't reduce the 30-day all-cause mortality. However, the finding trend, and this finding changed the current guideline recommendation and clinical practice. And the second, moderate or severe bleeding and peripheral ischemic complication is more frequent in the ECLS group. And whether to implant ECLS requires consideration of its potential complication that may influence the patient risk of death, including increased LV load, leg ischemia, stroke, or clinical significant bleeding. The active LV loading should be considered with ECMO. Thank you very much for your attention.
Okay, thank you very much, Dr. Ryu, and you nicely summarized the context of the ECLS-SHOCK trial, and also the current guideline and the current situation regarding the cardiogenic shock in patients with ACS. So, do you have is there some comment or questions from either the presenter or the panelist, or?
Yes, Dr. Minami, may I ask? Dr. Louis?
Okay, yeah, please.
Yes.
Yeah, so maybe I'm the only EP here among the speakers. Anyway, so the LV unloading idea, I think it's very interesting. So, but I don't have much experience on that. So how many ways you can do it? Can you just briefly summarize, Dr. Louis?
Yes, and for the use of the VA-ECMO, we can use the atrial septostomy, use atrial STEMI and insert the VA-ECMO tube into the LA. This is the most common use in the ECMO use. And also for other mechanical support, the leg impeder is more frequent use at present. Impeder can use for the can offer the mechanical support and also for the active LV unloading. And also there is other like IBB or the IFAC2 or the mechanical support also offer the benefit of the LA unloading. Of course, we can the CV surgeon can use the open heart for the LV unloading, but at present there's because there's invasive procedure, so there's less role in the surgical intervention.
Okay, Dr. Liu, can I have a brief question?
Yes.
So I think the VA-ECMO may be still important for some specific patient with cardiogenic shock caused by the acute coronary syndrome. So do you think what is the best way to differentiate the patient who can get the benefit from the VA-ECMO among all the cardiogenic patient with ACS?
Yes, but although based on the observation study and our clinical practice, some patients with cardiogenic shock really benefit from the VA-ECMO, but the high complication is like the peripheral ischemia and bleeding and also the stroke will worsen the outcome. So because I think the ECMO offers the potential risk to increase the LV afterload. So I think in the patient with cardiogenic shock refractory to medication, it's time for the mechanical support. But I think after the mechanical support use, if there is a sign of there is sign of hypokinetic LV dilatation and hypodynamic aortic valve opening, and also the high LV and diastolic pressure over 25 and refractory pulmonary edema, I think it's time to use the active LV unloading in this kind of patient. I think maybe combine use the LV active decompression in combination with VA-ECMO. I think maybe the survival benefit will appear.
Okay, thank you very much. Is there any other comment or question for this topic? Okay, so thank you very much again. Okay, we'd like to move to the next speaker. And next speaker will be Dr. Ahmad Hakemi in UAE, and he's a consultant in interventional cardiologist and structural heart disease in Cleveland Clinic, Abu Dhabi, UAE. So his topic is TAVR versus SAVR, a choice of therapy in severe aortic stenosis with a low surgical risk in elderly, implication of low risk and partnership. Are you ready to present?
Yes, thank you so much. I'm ready.
Okay, please go ahead.
Can you see my screen?
Yeah, sure. Yeah, please.
Excellent. Okay.
Yeah, please enlarge the slide. Okay, perfect. Okay, please.
All right. Good morning, everyone, or good evening. Thank you so much for the invitation. I really truly appreciate the hard work from the organizers. The topic, as mentioned, is TAVR versus SAVR for low surgical risk patients, especially with the focus on the newly published results of the EVOLU low risk and the partner 3 trials that were announced in TCT 2023. I have no relevant disclosures for this talk. The outline will be, I'll go briefly through what did we know from the earlier publications from the EVOLU low risk and partner 3 trial. and then I'll add on that what the new results showed and if there's any difference in the outcomes. And I'm going to describe briefly what's the current clinical practice and if those trials will have any implications on our practice as we speak. Starting with the EVOLU low-risk trial initially published in 2019, the first results. I'm going to take this off the screen. Yeah. So it was a randomized non-inferiority clinical trial focused on self-expanding bioprosthesis in low surgical risk. The definition for low surgical risk was a risk of 30-day mortality of less than 3%. The primary outcome was composite of death or disabling stroke at 2 years. I would want to highlight the notable exclusions of bicuspid aortic valve anatomy. Those patients were excluded, or any patient with left main or multivessel disease with moderate and high syntax score 22 and above, or any patients with other significant valve disease. It was predominantly an Evolute R platform, which is different than the current generation platforms we use. And most of patients actually had a pretty decent sized valves, 29 valve, predominantly around 40%. And the one after it is the 34 millimeter valve, and less to be 26 millimeter valve, and few cases where they had 23 or the 31, which doesn't exist in the market anymore. On the surgical arm, there was a nice spread of valve sizes as we see, but I want to highlight that almost 20% of patients had 19 and 21 millimeter valves, and root enlargement, in addition to the SAVR, was only done in 1.5% of cases. Around 13% of patients had CABG at the same time of the surgical AVR, and 3% of them had MACE. I want to highlight that the aging population were predominantly in their 70s or high 60s. As we see, the STS score was low as per study design, and the patients who were in dialysis were not really represented in this trial, which is also an important thing to mention. The first month and year outcomes published in the New England Journal of Medicine in 2019 showed that patients actually did better from the primary outcome of death or disabling stroke at the first month. However, that difference was not statistically significant going into the first year. And the first month difference was predominantly driven by less disabling strokes, which also was persistent up to the first year. So that was the first takeaway from this trial, that it appears that the first month and the first year, the rates of strokes were lower with the TAVR arm than the surgical arm. And also the TAVR arm had less incidence of acute kidney injury or heart failure hospitalization during the first year. However, there was a very clear signal towards higher permanent pacemaker implantation in the TAVR arm, around 17% in the first 30 days and 19% in the first year. I do want to mention that the technique of the valve deployment when this study was conducted is different than the current technique that we employ when we deploy the Evolute valve, with the focus on high implantation to answer as an answer to this higher rates of permanent pacemaker that was noticed in these trials. There's data published after three-year data published in JACC earlier in 2023 that showed that the difference in the primary outcome, the signal was consistent across the years up to 3 years. And there was a slight increase in the gap, actually, where patients who had TAVR had lower rates of primary outcome compared to the surgical arm. But if you look at each of them independently, none of them meet statistical significance. However, the overall primary outcome was in favor of TAVR over the surgical arm. Additionally, the TAVR arm had better echocardiographic parameters, including the mean gradient and the aortic valve area, which were lower with the TAVR arm compared to the surgical arm. Again, we confirm again that the permanent pacemaker rates are higher with the TAVR compared to the surgery. So surgery had the upper hand on that regards. And additionally, the rates of the paravalvular leak were lower with the surgical arm as expected. The caveat to that also is that the platform that we used then was the Evolute R, which is different than the current platform, which is the Evolute Pro Plus with the outside skirt. But that's also important to note that the rates of PVL are higher with TAVR compared to the surgical arms. Quality of life metrics up to 3 years show consistent improvement in quality of life, including cancer score and the 6-minute walk and the NYHA class. But there's a gap in the first month. Immediately after surgery, patients naturally take longer to actually feel better because of the nature of this intervention, which is more invasive. But however, that difference actually goes away after the first year, up to 3 years. And this signal is actually consistent even if when we look at the partner trial, the first month, usually patients who get surgery don't feel as well as their counterparts in the TAVR arm. Understandable. Moving on to the echocardiographic metrics up to 3 years. Consistently, the TAVR Evolute valve showed better effective orifice area, better mean gradients, and less incidence of patient prosthesis mismatch. However, again, the surgical arm had less paravalvular leak rates, which is similar to the previous publication. So not much surprises with the 3-year data. So what was added in TCT 2023 when we announced the 4-year data, we noticed that the primary endpoint of all-cause mortality and disabling stroke was also consistently in favor of TAVR, with actual increase in the gap between both arms. And that was continued to happen as the years go by. We see that difference in favor of TAVR continues to widen more. However, and not surprisingly, the permanent pacemaker signal remains to be in favor of the surgical arm. But when we go to the individual endpoints, they don't reach statistical significance, but the composite endpoint is the one that's statistically significant when it comes to all-cause mortality, disabling stroke, or rehospitalization. So that was one reassuring finding that TAVR continued to perform well, and the actual curves don't start to converge on each other. And actually, there's slight increase in the gap as the years go by. When it comes to quality of life, again, consistently showed that both arms do well after the first year. And again, reassuring echocardiographic parameters that with TAVR, the mean gradient, the aortic valve area, and the incidence of patient prosthesis mismatch is less than the surgical arm. Unsurprisingly, though, when it comes to PVL, the rates of paravalvular leak are less in surgical arm compared to the TAVR arm. However, we're talking about none and mild paravalvular leak. When it comes to moderate and above, there was no statistically significant difference between the TAVR and the surgical arm. One reassuring signal was the rates of valve reintervention up to 4 years. Again, we're talking about less than 2% rates of valve reintervention in both arms, the surgical and the transcatheter therapies, which was not significant among each other. However, the mean gradient more than 20 was, as I said, more in the surgical arm than the Evolute arm. So overall, echocardiographic data supports excellent hemodynamic parameters on the TAVR arm, the Evolute arm compared to the surgical arm. This is in summary what we know now about the utilization of the Evolute platform in low-risk patients. across those 4 years of monitoring. I'll start with the simple ones, is that pacemaker rates are higher with the EVOLU valve, and paravalvular leak is higher with the EVOLU valve. However, that leak is we're not talking about moderate and above. It's just the rates of non and mild leaks are more with the TAVR valve compared to the surgical arm. And the caveat to the pacemaker placement rates is that when this trial was conducted, the technique of valve deployment was different than the one we utilize these days. Overall, the safety and efficacy metrics have been reassuring in favor of TAVR, especially when it comes to the stroke rates in the first year, the bleeding rates in the first year, understandably, acute kidney injury in favor of TAVR, heart failure hospitalization the first year in favor of TAVR, and the primary endpoint, all-cause mortality and stroke, also in favor of TAVR. Quality of life are in favor of TAVR in the first month. However, that difference goes away after the first year. And echocardiographic parameters are also in favor of TAVR with lower gradients and less rates of patient-prosthesis mismatch after 4 years also, at 4 years mark. That was the EVOLU results. I'll just go briefly through the PARTNER 3 trial. What did we know about it? It was also published in New England Journal of Medicine 2019. It was a randomized non-inferiority trial focused on S3 SAPIEN 3 valve to treat patients with lower surgical risk. The surgical risk definition was less than 4%. Primary endpoint of death from any cause, stroke, and rehospitalization of 1 year. Again, notable exclusions similar to the EVOLU low risk. They excluded patients with bicuspid aortic valve. They excluded patients with left main or multivessel disease with high syntax score, more than 32, or who had other significant valve disease. Most patients underwent the TAVR arm had a 26 size valve, which is a decent size. Around 20% of them had 29, almost 30% of them had 23, and very few of them had 20 millimeter valves. When we look at the surgical arm, almost again, 20% of them had 19 and 21 millimeter valves, relatively smaller size. And again, 13% of them had CABG, 5% of them had MACE, but root enlargement happened in 5% of the surgeries compared to the 1.5% of surgeries that happened in the EVOLU arm. Again, similar age group in the 70s, high 60s, low STS score patients. This is the baseline characteristics. The 1 year outcomes showed that that was a big surprise for everyone, that actually TAVR outperformed surgery in the first year when it comes to the primary endpoint of death, stroke, and rehospitalization, which was predominantly driven by rates of stroke and rehospitalization. Also, TAVR outperformed when it came to risk of bleeding, understandably, or transfusion need in hospital. More patients with surgery had new onset atrial fibrillation. The rates of AKI were less with TAVR compared to surgery. The sternotomy, obviously, minor access site complications were in favor of TAVR also. And more patients who had TAVR went home compared to surgery. Some patients will end up going to SNFs and advanced care facilities. However, the metrics that were in favor of SAVR at the first year were the left bundle branch block, understandably, and obviously the vascular injury was more with the arm of TAVR compared to the surgical arm. Moving on to the quality of life metrics, similar signals we saw with the EVOLU low risk trial, that overall patients in the first month do better if they have TAVR compared to surgery when it comes to quality of life metrics, understandably, because of the invasive nature of the surgical approach. Actually, in the first 30 days, patients walk less than the 6-minute walk when they get surgery. Again, that's not truly surprising. When it comes to echocardiographic parameters, actually this time surgical AVR had better mean gradients at 1 year, less PVL at 1 year, and less rates of moderate patient prosthesis mismatch. So the surgical arm had the upper hand when it came to the echocardiographic parameters in the PARTNER 3 trial. So less leaks, less patient prosthesis mismatch, and less mean gradients. That's at the first year follow-up. In 2021, the 2-year data came out for the PARTNER 3 trial that showed, again, consistent outperformance of the TAVR versus the surgical arm when it comes to the primary endpoint of death, stroke, and rehospitalization, but the gap is actually narrowing. That was one thing that people noted back then, is that the gap between those two arms is narrowing. However, it was still statistically significant. So the metrics favoring the TAVR were death, stroke, hospitalization at 1 and 2 years. Again, stroke, TAVR outperformed SAVR and with stroke rates, with rehospitalization rates, with the rates of new onset atrial fibrillation. However, at 2 years, we started noticing a signal of valve thrombosis that was in favor of surgical arm. So patients who had TAVR had more rates of valve thrombosis compared to the surgical arm patients. And that was a signal that got a lot of attention. Quality of life metrics did not really change a lot at 2 years. Again, consistent benefit at 2 years. Both arms were equal. Echocardiographic parameters at 2 years showed again that the gradients remained to be lower with the surgical arm compared to the transcatheter arm. Also, they had less leaks, but those leaks were also none and mild, where there was no difference when it came to the moderate and severe leaks. They were low in both. But again, at 2 years, as I said, we noted that there is a signal for valve thrombosis detected at 2-year cutoff. The valve thrombosis basically were detected by increased gradients or new onset AI, or even a CT scan showing the clot. And most of those patients presented with a CVA or a TIA-like symptoms, basically. What was added, PARTNER 3 trial, at TCT 2023, 5 years data was announced and published in New England Journal of Medicine. We showed that the graphs actually continue to converge to each other, and the difference is less, and now it's not statistically significant. And that was mostly driven by more death from any cause that occurred in the TAVR arm compared to the surgical arm. However, that difference was not statistically significant, but probably that's why the graphs are converging on each other. The atrial fibrillation remained an issue with the surgical arm, so less patients who had TAVR had AFib compared to the surgical arm. However, again, we see that patients with TAVR had more likelihood of having valve thrombosis compared to the surgical arm. And but still we're talking about rates of less than 3%. 2.5% or 2%, basically. But that signal persisted up to 5 years also. So that was also worth mentioning and noting. Quality of life, not much difference going into the 5th year, consistent benefit among both groups. Echocardiographic parameters at 5 years, again, the same message is that the surgical valves had lower gradients and lower non to mild PVL compared to the TAVR arms. And again, we see the signal of the valve thrombosis, as we mentioned. However, the reassuring thing was that the repeat valve intervention in both arms was still less than 3%, with no difference between both groups. So that was another reassuring signal about durability of TAVR as a therapy going into the 5th year. Which is something important, obviously. Overall, the PARTNER 3 trial, I'll start with the surgical arm. The surgical arm metrics that favored it included valve thrombosis. So surgical valves had less valve thrombosis than TAVR valves. And the echo parameters, including the mean gradient and the PVL rates, non to mild. And the patient prosthesis mismatch, but that was only up to 1 month. When it comes to the clinical outcomes, early on, the first 2 years, TAVR outperformed based on the data that we have. TAVR outperformed surgical arm. However, that difference actually was not statistically significant as at 5-year landmark, and actually the curves are converging on each other as the years go by. On the short term, obviously the transfusion rate, the new onset of atrial fibrillation, the acute kidney injury, they were all better with the TAVR arm, basically, and the first month was of quality of life metrics were better in the TAVR arm. So some differences among both trials, the way which therapy took the overhand over the other. However, I want to be cautious about direct comparisons between EVOLU versus Edwards, because these are two separate trials, two separate patient population with unaccounted for variables. So we have to be very careful not to compare between different platforms at this stage until we have dedicated data. What is the current clinical practice? Well, since all those trials came out starting the early 2000s, the TAVR became more or less mainstream therapy for aortic valve replacement. And this is data about real-life data from national trends in TAVR versus SAVR in patients with isolated aortic stenosis. Very nice work published in JACC in 2022, where they tracked the volume of cases from 2015 to 2021. We see even in younger patients, less than 65, there was an increased uptick in TAVR as a therapy for those patients. This is especially true if the patients had no bicuspid valve and they had no, or they had prior coronary artery bypass. So there's going to be a redo for them if they have a SAVR, or if they had heart failure, so probably sicker patients. But the signal is clear that even in younger patients now, TAVR is being adopted, and that's obviously when you're older, more 65 and 80, this is not surprising, but the signal here was obvious also, that even if you're younger, you ended up getting more TAVR these days than before. This is some data from France showing kind of similar adoption of TAVR, but more towards the older age rather than the younger age. So if you're less than 75, you still see an uptick as the years go by. However, this is more prominent as you get older, from 75 and above. The guidelines are actually the American guidelines, the US guidelines from 2020. You start with the risk assessment. If they're high, then your TAVI is the only option if your surgical risk is high, more than 8%. However, if you're low or moderate risk, it becomes an issue of age and life expectancy, and I'm going to touch base on where did the age cutoff come from. But if you're less than 65 by the US guidelines, surgery is the class 1 indication. If you're more than 65 to 80, then both are available as therapy. If you're more than 80, TAVR has the upper hand. The European guidelines kind of follow the same track of thought process. However, the age cutoff is different. They're mentioning 75. If you're less than 75 and low risk, they recommend SAVR. If you're more than 75 or have a high risk, they're recommending TAVI, and there's the spectrum in between. Where did those age cutoffs come from? Well, it depends on the life expectancy. In the US, if you're at 65 years old, your life expectancy is from 16 to 19 years old, depending on gender. As you get older, obviously the life expectancy gets less. If you're 75, it's around 10 years if you're a male, or 12 years if you're female. So obviously the decision making will take into account the life expectancy and durability. However, we all know that life expectancy is a moving target, not only as the years go by that might change, but also depending on where you practice medicine. Some countries, patients are expected to live longer compared to others. For example, I put the numbers for someone who's 65 years old in the UAE, the life expectancy is around 82 years, up to 82, so it's 17 years. If you're 75 years, it's around 10 years. So I do want to emphasize that, and as we see here, if you live in Africa, most of the time you have lower life expectancy compared to if you live in Europe or North America. So I think that's a caveat that we should all incorporate in our clinical decision making when we discuss therapy options with our patients. What are the implications of those results on our clinical practice? I would say so far we still have a safety signal when it comes to TAVR as a therapy option for low surgical risk patients. And also it's an effective therapy. It's safe and effective. However, durability right now, we only have, it's an intermediate follow-up metric. We're not talking about 10 years follow-up, so we still need that data. If we're going to actually start changing the age cutoffs, if we're going to even do it at the younger patients, then we definitely need much longer follow-up with the low-risk population. Hopefully, the 10-year outcome will shed some light on that. We should avoid inferencing superiority between TAVR platforms based on those indirect comparisons. After those trials came out, we started seeing a lot of discussions that one platform has the upper hand over the other platform. We should all remain strict in our interpretation of randomized clinical trials. We should always interpret them appropriately and not try to inference superiority measures. And when it comes to the low-risk patients, other factors that I think are important to incorporate in any clinical decision is we have to remind ourselves that bicuspid anatomies were excluded. Patients who have multi-valve pathologies were excluded. So all those are common scenarios that we have to incorporate in our decision-making. We have to think about the future need for coronary access, and we have clear data about one platform outperforming the others in these regards. And we have to incorporate the national life expectancy. Wherever we practice, we have to take that into consideration whenever we have those discussions with our patients. And we have to think about the lifelong management of severe aortic valve stenosis. What's the durability of the TAVR bioprosthesis that we have? Are we close to what the surgical valves we know can last? And also, what's the technical feasibility of valve-in-valve, TAVI-in-TAVI across different platforms? If you use a balloon expandable one now, is it easier to do another TAVI in the future? Or if you start with a self-expanding one, is it easier to do another TAVI in the future? So all those things we should incorporate in our decision making. Thank you so much.
Okay, thank you very much, Dr. Hakemi, for your wonderful lecture regarding the excellence of the TAVR over SAVR in low-risk patient. Is there any comment or the questions? Okay, so thank you very much again, Dr. Hakemi. Nicely summarized the excellence of the TAVR over SAVR. Thank you very much. So I'd like to move to the last presentation, which will be provided by the Dr. Nantipawat. It's very difficult to correctly pronounce. I'm so sorry. From Thailand. He is Assistant Professor, Division of Cardiology, Department of Internal Medicine, Faculty of Medicine, Chiang Mai University, Chiang Mai, Thailand. Topic of his talk is cardiac resynchronized therapy upgrade in non-ischemic and ischemic HFrEF with dependent right ventricular pacing and ICD backup. Please go ahead.
Okay, thank you, Dr. Minami. Okay, so it's really my honor to be here, join the meeting today. So I have nothing to disclose. So as we know that the problem about the right ventricular pacing or RV pacing is that it can cause a pacing-induced cardiomyopathy in about 10 to 20% of the patient. And the reason of that is because when we pace the RV site first, then you create the interventricular dyssynchrony by contracting the RV first and then later on the LV. And not only that, you also cause the intraventricular dyssynchrony by you delay the contraction of some part of the LV wall. So the posterolateral wall of the LV will contract later when you do the RV pacing. And this problem has been known for a long time, like in David trial. This is a trial that they try to randomize patients that have EF less than 40% to BVI 40 versus the dual chamber DDR rate 70. And as shown here, you can see that the patient who has DDR mode obtain more ventricular pacing, and that leads to the worst clinical outcome of death and heart failure hospitalization. And when you look at the percentage of the RV pacing, we can see that the patient who receives the RV pacing more than 40% has the worst clinical outcome as compared to a person who has less than 40% RV pacing. And another trial, this is the MOSE trial, also shown a similar finding. This is about 1,000 sinus node disease patients, and they randomized to the dual chamber mode or DDR versus the single chamber mode BDI or 60 beats per minute. And they have shown that regardless of the mode, actually, if the patient had more RV pacing, more than 40%, they have worse outcome in terms of the heart failure hospitalization and also increased risk of atrial fibrillation. So now we know that the pacing-induced cardiomyopathy caused by the dyssynchrony of the RV pacing. So the next question would be, can we reverse it with the cardiac resynchronization therapy or CRT? So I bring this trial to show you that they enroll about 800 complete heart block patients, EF more than 40%. And so they define the pacing-induced cardiomyopathy as the patient who later received the CRT upgrade or later the ejection fraction drop to less than 40% after they implant the pacemaker. And the graph here shows that the patient who received more than 20% RV pacing had a strong association with the incidence of pacing-induced cardiomyopathy. And the diagram here shows that the incidence of PICM here occur about 12% of the patients. And among them, only 1/3 or about 30% received the CRT upgrade. And among the patients who received the CRT upgrade, they have a very high response rate, meaning the ejection fraction after the CRT upgrade improved up to 20% of LV ejection fraction. This is another trial showing the patient who have a pacing-induced cardiomyopathy, and the mean LVEF at the starting was about 30%. So after the upgrade, by 1 year, the LV ejection fraction improved to 45%. And if you look at the patient who have the EF starting less than 35%, after the upgrade, 70% of them EF improve above the 35% and do not need the defibrillator anymore. So the CRT is highly efficacious in reversing the pacing-induced cardiomyopathy. So yes, we can reverse the PICM with the CRT, demonstrated by the improvement of the ejection fraction or the LV systolic volume. But does this improve of the LVEF by the CRT upgrade actually translate to the better clinical outcome, or it's just the number? So this meta-analysis include about 400,000 patients de novo CRT versus about 20,000 patients who received the CRT upgrade. And the baseline LVEF is less than 35%. So the diagram here showing that the ejection fraction improved similarly among the patient who has the new CRT device versus the upgrade. And also the upgrade population had derived the similar benefit of the improved heart failure symptoms as the de novo group. But we have to keep in mind that with the upgrade procedure, the complication rate were higher than the new implant. For example, like a perforation, pneumothorax, and the lead dislocation. With the same analysis here, they show that the risk of mortality and the heart failure risk among the patient who had the de novo CRT versus the upgrade CRT derives a similar benefit. But this is the observational study. So it could be the bias that the patient who receives the upgrade is the one who physician thinks that they are not too sick. So this led to the 2021 ESC guideline that if the patient have the LVF less than 35% with a significant proportion of the RV pacing, and they define as more than 20% of RV pacing, there's a 2A recommendation for the upgrade to the CRT. Now, this year, there was a meta-analysis, another one that came out that showing that the patient who had pacing-induced cardiomyopathy, there's IEF about 35 plus minus 10. And if they receive the CRT upgrade, the LV ejection fraction improved about 5 to 10%. And also the functional class improved by about half or one step. But we have to remember that this meta-analysis include only about 5 RCT, which is a very small, and it was a crossover design. So we cannot look at the hard outcome like a heart failure hospitalization or mortality. And so this led to the guideline this year from HRS, APHRS, and the LAHRS in 2023 that in patients with the CIED that have a decline LV function or worsening heart failure symptom attributed to the substantial RV pacing, and they define as more than or equal to 20%. CRT with BIV is recommended to improve the LV function and the heart failure symptom. So yes, the better LVEF from CRT translated into the better functional class, heart failure, and mortality. But all the information we had earlier is from observational studies. So this is when the Budapest CRT upgrade came into play this year. So what it is, this is the international randomized control trial of about 360 patients. So they enroll the patient who have a heart failure reduced EF of less than or equal to 35%. All of them had RV pacing more than or equal to 20%. And the pace QRS has to be wide, more than 150. And they randomized the patient to upgrade to CRT-D versus just upgrade to the regular defibrillator. And they follow up patient for 12 months. So the primary endpoint was the composite of the all-cause mortality, heart failure hospitalization, and the echocardiographic parameter, which is the less than 15% reduction in LV and systolic volume. So the baseline characteristic in this trial show that the patient is about 70 years old. They enroll symptomatic heart failure patients, class 2 to 4, but mostly they were in class 2 and 3. EF is about 25%. And all of them receive a good heart failure medication. And you can see here that the patient in both arms had the RV pacing about 85% of RV pacing. So it's pretty high RV pacing. And about the underlying medical condition, about 56% of them had atrial fibrillation. So when you compare to the prior CRT study, to the Budapest CRT trial, you can see that the age in Budapest CRT is older if you compare to MADIC CRT, RAF, or damage. And the proportion of the atrial fibrillation is higher than the other trials also. The New York Heart classification is also higher, and the mean LVEF is low at about 25%. So, Budapest CRT is dealing with the advanced heart failure population. So will the upgrade improve the outcome? So you can see here that the patient who receives CRT-D have the better primary composite endpoint with the odds ratio of 0.11. But if you would like to just look at the heart outcome, which is the secondary composite endpoint of mortality and heart failure hospitalization, the CRT-D still superior as compared to the ICD arm with the odds ratio of 0.27. Regarding the safety outcome, the serious adverse event from the procedure in both sides is similar, slightly higher in the CRT arm. The VT and VF is significantly less in the patient who receives upgrade to the CRT. So I think in the future, the statement for the guideline may have stated this statement more strongly. Like if the patient has EF less than 35%, attributed to the RV pacing more than 20%, CRT is recommended to reduce the all-cause mortality, heart failure, hospitalization, and ventricular arrhythmias. So the question remains is that how about should we upgrade CRT in the patient who has the better LVEF, for example, like 36 to 50%? And the only randomized trial that we have to support is to answer this question is the block HF. But the block HF is the study about not the upgrade, but they compare about the new CRT implant compared to the new RV pacing in the patient who have EF less than 50% with the high-grade AV block. And this trial showed that the CRT had a better outcome in terms of the death, heart failure, and the echo parameters. And the primary outcome are mainly driven by the reduced rate of the heart failure hospitalization. How about the even earlier upgrade CRT in pacing-induced cardiomyopathy in the patient that EF dropped more than 10%, for example, like 65 to 55? Should we do the upgrade? I don't think we have enough information to answer this question yet. How about upgrade to the conduction system pacing? So in 2023 guideline for cardiac physiologic pacing, they gave the class 1 recommendation to upgrade to CRT with BIV, but they also give the 2A recommendation that the conduction system pacing is also the good alternative. And this came from the systematic review and meta-analysis that published this year. So they include about 8 observational studies, but it's a small study. And they show that the LVEF and the functional class improve significantly and actually looks even better than the CRT upgrade population. So in summary, pacing-induced cardiomyopathy occur about 10 to 20% of the patients who have the substantial RV pacing, more than 20%. Budapest Upgrade CRT is a randomized trial that shows that the CRT upgrade can reduce the mortality and heart failure hospitalization in both ischemic and non-ischemic LVEF less than 35% with a significant RV pacing. So, this trial confirmed us that we should be careful on monitoring the EF percentage of RV pacing and the heart failure symptoms when we follow this group of patients and upgrade to the CRT without delay if we found that the patient have symptomatic heart failure. For the PICM that has EF more than 35%, but less than 50%, I think there's possible benefits from what evidence we had. But for the EF more than 50% is still uncertain. And the conduction system pacing upgrade evidence is still ongoing and coming in the future. Thank you.
Thank you very much for your nice presentation regarding the CRT upgrade in the BUDAPEST CRT upgrade trial. So is there any comment or questions? So can I have one brief question? In this, the BUDAPEST CRT upgrade trial had included the patient with pacing rate more than 20%, right?
Right.
Yeah, but I think, as you had presented in your first several slides, the pacing rate more than 40% is also, the kind of cutoff level for the, adverse event in the future, right? So in this, the BUDAPEST CRT upgrade trial, as I guess some patient may have the 100% pacing and some other patient may have the 30% or 40% or something like that. So is there any, the difference between them, or do you have any comment regarding that point?
Actually, I don't see their subgroup analysis yet, but I think this is a very good question. I think in the future, I think we might see the post-hoc analysis of the data from Budapest. But the reason they use the cutoff of 20% is that there are also multiple studies in the past that show that just 20% or more is enough to cause the pacing-induced cardiomyopathy also. So I think that's why they choose that cutoff. But yes, I think to do the post-hoc subgroup on whether there are the different benefits or not, I think that would be interesting.
Okay, thank you very much. Okay, so is there any other questions or comments for his presentation? Okay, so thank you very much again for your wonderful lecture. Okay, we have completed total 6 presentation regarding the cutting edge topics in this year. So I'd like to give the final closing comment for this session. So I presented regarding a topic of the complete revascularization, and Dr. Khan from Korea will summarize the importance of the intracoronary imaging, and also we had shared the topic regarding the physiological assessment and what is the best strategy for the shock patient, and the TAVR versus SAVR, and the last topic is regarding the CRT. Then we have shared many cutting topics in the field of cardiology, and I hope this, the wonderful opportunity will contribute to better changing your daily clinical practice and subsequent better clinical outcomes of Asian cardiology patient. So thank you very much for joining this wonderful session. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you. Thank you all. Bye-bye.
Thank you very much.
Thank you.